pleased to welcome Associate Professor David Sullivan, who's joining us from the immense distance of the other side of Missenden Road. David is a very good neighbour and friend of the Biobank. He's also he's a senior staff specialist at Royal Prince Alfred Hospital, where he's also head of Department of Chemical Pathology. And David has long-term research interests in lipid metabolism, and he's going to be sharing some of those interests with us today around cardiovascular disease. So his talk today is titled Biobanks Pay Dividends, Presentation of Cardiovascular Disease via Prevention, can't read my own writing, of cardiovascular disease via Mendelian Randomization studies. So now I'm going to hand over to David and make sure that you can all see the slides.
Well, good afternoon, everyone. That was just a ploy to make sure I could say good afternoon instead of good morning. And I'm very grateful to Jennifer for her kind introduction and the opportunity to speak to everyone today. My topic sounds a little bit economic, but in fact, what we're really doing here is trying to improve our odds in the great gamble of making health improvements. So this is a possibility with a technique known as Mendelian Randomization, and I hope to describe some of its characteristics today. And of course, it's a great era for biobanking. There are so many opportunities there. Biobanking, I think, in many ways is an exercise in descriptive science. The samples come in and you typify what's actually happening with that. And that's led to a situation where the approach has led to measurement of biomarkers, the examination of associations with diseases and side effects, etc. And this is now, I think, exemplified by studies like GWAS associations. And now we're making those associations in other directions towards phenotypes or side effects and other things like that. And we've even reached the stage where you might talk about hypothesis-free diagnosis. There's the example in the literature of a newborn child with obvious abnormality of metabolism that was life-threatening. They did a genome-wide, did a genome sequence in the 24 hours between birth and progress in the ICU, and they made the diagnosis within 24 hours and treated accordingly. That sort of information typically has fed on through approaches to try to come up with interventions, and we've used many approaches, starting years ago with molecular panels, screens, etc., animal models, increasingly starting to use animal knockout models, and the results there haven't always been successful, and we look towards Mendelian randomization maybe being a much more successful approach, one which will increase our yield in terms of useful interventions. I'm just going to start by maybe describing a small case study for you. A 33-year-old woman who had chest pain, angina, who also had a cholesterol around about 8 to 9 millimoles per litre. And you'd appreciate that's not your average patient. She started appropriate treatment with first and second line cholesterol lowering treatments, statins and ezetimibe, as well as some other treatment. But despite this, her coronary artery disease progressed, and she needed stenting of first of all 2 vessels, and then a further stent 2 years later. And she came to see us a year after that. Physical examination didn't identify any particular problems, although there was maybe a little bit of a lump in her right Achilles tendon that we might think of as a tendon xanthoma. We suspected a condition called familial hypercholesterolemia, which we could talk about if anyone's interested, but essentially it's inherited high cholesterol with a personal family history of coronary artery disease, the tendon xanthoma, as I mentioned. We've got clinical scores to try and look at how likely we think the diagnosis is, and the treatment requires sort of high-level potent statin treatments like the atorvastatin that was switched to the rosuvastatin. We even got desperate and added a bit of vitamin B3 with nicotinic acid, and we got levels of LDL cholesterol, which had been around 7 or 8. We got them down towards 2.2, but they drifted up towards 6 on occasions as well. And then this lady finally had a myocardial infarct in 2007, required coronary bypass grafting in 2009. We actually did the gene testing to show that she had inherited this condition, which was due to a novel duplication of particular exons in the LDL receptor. We could show through cascade testing that the main at-risk individual, her son, was not affected. And she has now progressed to our latest treatment, a treatment called a PCSK9 inhibitor. But even with that treatment, she was still registering unacceptably high levels, and she was still getting angina. And she was assessed as really not even being terribly suitable for further revascularization studies. So we offered to put her in a trial of really the next item we've got available, which is a thing called an anti-ANGPTL3 agent, an ANGPTL3 inhibitor. And you can see we're just sort of grabbing these sort of names out of the blue. What on earth would make you think that an ANGPTL3 inhibitor is going to help in this particular situation? And this is what I hope to illustrate today, is that the technique of Mendelian randomization, which, if you like, is nature's clinical trial, is a tool for discovery of biomarkers, therapies, and can even be used to probe side effects. And of course, the classic method of showing the effectiveness of a treatment is to conduct a prospective randomized controlled trial. And we usually do that when the patient's well into the disease process. We have a control and intervention groups. We trust statistics to reach a stage where the confounders have been randomly distributed between the two groups, and we come up with a prospective risk of the outcome of interest. And that is, even under best of circumstances, somewhat prone to further confounding. Whereas the situation with Mendelian randomization is really secure from that problem, because it's relying on the fact that when we are conceived, the alleles for our different attributes segregate randomly so that we have carriers or non-carriers of the different attributes. Subsequent to that, through the rest of our life, all the other influences, the potential confounders, will be evenly distributed completely according to chance. And therefore, if we do a cross-sectional study, the genetic information can inform us about the risk of the outcome of interest, and particularly can look at a potential for drawing conclusions about causality from observational data, which you can't do under usual situations. And so here it is, the ability to infer causality from observational studies. And I think best if I start off with an example for you, and I thought I'd look at the question, does cholesterol lowering cause cancer? Because we observe patients with low LDL cholesterol levels do have higher rates of cancer, but there are a number of confounders that could account for this, and then there are a number of other biases that could come into similar sorts of studies. So we do want to try to avoid those. We think we can avoid them by Mendelian randomization, in which we would look at the wild type non-carriers as the control group, and we'd look at people who are carriers for alleles which lower LDL cholesterol. Confounders will then be randomly distributed, and we should get an expression of the real relationship between low LDL cholesterol and cancer. So just to typify that in graphical forms, we think there's a relationship between low LDL cholesterol, that's lipoprotein, and cancer cells. We know there are some genes which influence LDL cholesterol to make it lower. We examine populations to see what the relationship is between those genotypes and the risk of cancer, and that should define for us the nature of the relationship between those two attributes. And if you're in any doubt, there's certainly plenty of observations to say that people with low LDL cholesterol levels do tend to have cancer. whether it be, well, that's just a general observation. And so here's our Mendelian randomization study. Here are the gene variants which are causing a slight change in LDL cholesterol level, tending to lower it, not by much, but just a little bit. And you would predict that that amount of cholesterol lowering should be associated with an increase in cancer, which you can see in different scenarios reaches statistical significance. But when we look at the actual observed relationship, we find no relationship between those genotypes and the risk of cancer. So if we go back to our previous model, we've suspected the relationship, we've looked at the genes which lower LDL cholesterol, but they do not affect the risk of cancer, and therefore we think the relationship is non-causal. We think it's probably due to reverse causation by distinction. So this technique of Mendelian randomization has helped us in all sorts of other ways, particularly in our metabolic field, where there are a number of features which make it particularly useful. And first of all, I think it's been possible to look back or even look at in real time to appreciate that our routine treatments follow the principles of Mendelian randomization and suggest themselves as good targets for therapy. And sometimes this is necessary because if you think about it, we had to prove the efficacy of our second-line treatment in patients who were fully treated with first-line treatment. That was just an ethical requirement. And so that, of course, lowered the event rate and made it extremely difficult to do a powerful enough study to provide that proof. And so 7 years after they started the study, they were just on the verge of announcing the results, and a publication appeared in the New England Journal predicting that it was going to be successful. And it was a prediction based on Mendelian randomization. It said, here are the loss of function mutations which can affect the absorption of cholesterol. If we look at those collectively in different populations, the meta-analysis says they are responsible on average for around about a 12.5% reduction in LDL cholesterol levels, and that in those same populations was associated with a 50% reduction in coronary disease rates. So fulfills the criteria of Mendelian randomization, suggests that LDL is causal for coronary disease, and more particularly that strategies directed at the target for cholesterol absorption, NCP1L1, would be successful in lowering LDL cholesterol. And I won't bore you with the details, but they were. I'll just use this slide to show that here we have the accumulation of the outcomes data. Here are all of the mutations with around about a 1/7 rate of coronary disease in those with loss of function, compared to around about a 1/2 to 1/3 loss coronary heart disease rate in those with normal function. So around about a 50% change. So if we go through our construct again, just for the sake of it, yes, there is a relationship between that variant and coronary disease. So yes, the LDL and coronary disease relationship is causal, and strategies which target NCP1L1, that particular gene change, should be successful. Now, I hope you were as impressed as I was, and I hope you'll be even more impressed in some future slides with the strength of that degree of protection. There was a 12.5% decrease in LDL cholesterol and a 50% reduction in the coronary disease rate risk. Now, to compare that to the sort of information you get from clinical trials, I'd have to tell you about some trials you don't hear about very much because they didn't lower the LDL cholesterol very much. Here are some similar trials lowering it about sort of 12.5, lowering it by around about 12.5% over about a 5-year trial. What you see with the genetic information is the same degree of cholesterol lowering, but of course it's sustained for whole of life. And being a cumulative sort of a condition, the effect is augmented over time, and the degree of protection is very substantially augmented over time. And so as much as anything else, this serves as an encouragement for early intervention, because the longer you sustain the favourable change, the more powerful the reduction in the event rates. And that's certainly been the case with that new treatment I mentioned, which was that entity called PCSK9. Now, we discovered first of all, just to tell you what PCSK9 does, when you synthesize an LDL receptor to capture LDL particles, to internalize them and remove them from the circulation, you produce in parallel, probably for reasons of fine tuning, an entity called PCSK9, which binds onto the receptor, and instead of the receptor recirculating to the surface and acting again, it is directing the LDL receptor to be degraded in the lysosome. And so we discovered, as I'll show you in a minute, cases of familial hypercholesterolemia that were due to excess PCSK9 that caused a deficiency of receptors, an increase in cholesterol, and typical familial hypercholesterolemia. Where there is the possibility of a gain of function mutation, there's also the possibility of a loss of function mutation, and that provides the seed for our Mendelian randomization approach. So if I tell you the story of PCSK9, it starts with familial hypercholesterolemia, where affected families we usually examine in terms of mutations in either the LDL receptor or its ligand, the ApoB molecule. However, it was clear from genetic association studies that that did not explain all the cases of familial hypercholesterolemia we could find. And so gene association studies again indicated that link with PCSK9 and showed that it was a change in the PCSK9 gene, again a function mutation, that explained some of the cases of familial hypercholesterolemia. Now, the graphic's a bit out of whack, but applying the knowledge then of a loss of function mutation, we do the Mendelian randomization exercise, and we find that a loss of function mutation of PCSK9 reduces LDL cholesterol by around about 30%, and that causes a massive 90% reduction in coronary disease rates, and this was particularly done in the Dallas Heart Study. And in addition to that, those patients were well and healthy, and so it suggested PCSK9 as a powerful and also a safe target for treatment development, and that's fostered the development of a whole new paradigm of therapeutic research. And so we'll go into that in a little bit more detail to try and show you some of those benefits. So it starts with Mendelian randomization suggesting a potential target like PCSK9. It's done on a genetic basis, so we know the sequence for the gene, so we know the sequence for the messenger RNA, so we can design some lead compounds as antisense messenger RNA and have those into in vitro testing very quickly, progressing to animal experiments very quickly, progressing to human experiments very quickly. And so here we have the anti-PCSK9 antisense called inclisiran. It has completed proof of concept testing. PCSK9 was discovered in 2003, and inclisiran was under trial by 2013. So development was occurring over about a decade, whereas usually it takes about 3 decades to develop a product. So first of all, there's an efficiency with the speed of development. Second of all, we know from the Mendelian randomization studies that these patients are generally well, so there's a greater expectation of safety. Thirdly, we know from the Mendelian randomization studies that it looks like that theoretically it should work, so there's less futile exercise in terms of inappropriate trials. And just finally, you might wonder about PCSK9 antisense. It would often be compared to an antibody against PCSK9. Antisense messenger RNA is a chemical sort of production process. It's much cheaper, and this product here only needs to be given once every 6 months, and so on that basis, you're looking at pretty reasonable treatment costs. So that was the story behind the treatment which this lady received, which was helpful but not helpful enough. And so she then progressed to the product evinacumab, which is the anti-ANGPTL3, which should lower LDL cholesterol by another 20 to 30%, and triglycerides will be reduced as well. And the trials have been helpful in that direction. So that's been looking at the development of some successful treatments, and now with the wisdom of hindsight, we can look back and see why some of our other treatments didn't work, again using Mendelian randomization. And part of this is built around the fact that we got preoccupied with the idea that HDL is the good cholesterol and what we should do is boost it. Well, there's a complex relationship in which HDL cholesterol is virtually always inversely related to triglyceride levels. So when you've got when you've got a low HDL cholesterol, a possible high-risk situation, you've virtually always got a high triglyceride. And Mendelian randomization has taught us that it's actually the high triglyceride that's the problem, and trying to boost HDL cholesterol won't do us any good. So here's our typical relationship, our biomarker and our genetic markers showing you that LDL cholesterol is consistently a risk factor for both biomarker and LDL and genetics. But for HDL, we don't see that. We see it's a risk factor for the biomarker, but not for the genetics. Whereas if we take markers of triglyceride-rich particles, so-called remnant particles, we find that again the genetics and the biomarker and the genetics agree and identify triglyceride as an appropriate target for reduction because it's a causal risk factor for cardiovascular disease, and HDL cholesterol is not a protective marker for cardiovascular disease. So again, we can then use some of this information to find some useful new treatments. So it's turned out that control of triglyceride is much more complex than we thought it was. You look very carefully at the removal process for triglycerides. It involves an enzyme called lipoprotein lipase, but that enzyme is controlled by lots of on-off switches, and one of those switches, and they are things like ApoC2, ApoC3 on-off, ApoA5 on, ANGPTL3, ANGPTL4 off switches. And so we're particularly interested in the off switches because we want to boost the removal of triglyceride. And so we concentrated interest on ApoC3, which is an off switch. And here we have two genetic polymorphisms for loss of function ApoC3. And you can see that in both cases, they're associated with a reduction in coronary heart disease risk. That's been applied and has had the effect of lowering triglyceride. Here you see people with massive triglyceride. You see the overwhelming response in a dose ranging study was reduction in triglyceride levels, taking people with massive triglyceride down to much more manageable levels of triglyceride. And not only should this be helpful for coronary disease, but these people face a risk of acute pancreatitis because the pancreas thinks it should digest the fat in the blood. And by reducing the amount of triglyceride down to a threshold of around about 5 millimoles per litre, we can avoid that complication. And just to take the other side of the coin there, we spent an awful lot of time trying to boost good cholesterol. And it's a wonderful definition of a completely futile study, absolutely no benefit. And this was done for 4 separate agents. The last one actually finally did get an endpoint benefit, but that was because it lowered LDL cholesterol as well, and the benefit was only proportional to the LDL cholesterol lowering. It had nothing to do with HDL raising. And so it might come up on the next slide, but the frustration here is that we wasted 10 years and probably about $15 million on efforts to boost HDL cholesterol. And And so you can then actually use Mendelian randomization to say, well, is there a reason why the CETP inhibitors didn't work? And an interesting approach here, a positive score shows it's as if the CETP inhibitor is as if the CETP is inhibited, and if it is naturally loss of function reduced in individuals, yes, you do get some degree of cardiovascular protection, but that's only if a similar scoring approach judges that there's no loss of function as far as the statin target HMG-CoA reductase is concerned. Just about everyone who would receive a CETP inhibitor would probably be on a statin, therefore they would have an HMG-CoA reductase type effect, and it seems that under those conditions, genetic decrease in CETP activity is no longer protective. The protection is lost. So we've been able to use Mendelian randomization to assess useful and not so useful treatments. We can also use it as a way of assessing safety, or in some ways of anticipating what side effects might come if we had a successful targeting of a particular aspect of metabolism. And so the first question with such a powerful agent as anti-PCSK9 therapy was it safe? Because we're getting down to very low levels. We also had a little bit of concern that statins were now starting to show a little bit of a tendency towards new onset type 2 diabetes. So once again, a Mendelian type scenario from just the two cases that are known in the literature of double homozygous loss of function PCSK9 mutations. These patients have extremely low cholesterol levels, around about 0.5 millimole per litre, but they are completely healthy and completely normal physiology, etc., reproductive life, etc., etc. So there's no suggestion of any adverse effect, and I suppose for extra reassurance, PCSK9 knockout mice are completely normal development, normal fertility, etc., etc. So again, using the genetics to explore the likely safety. And when looking at probably a real problem, we recognise that patients receiving statin therapy probably do have a slight increase in new onset type 2 diabetes. And here you can actually see that polymorphisms of PCSK9 predicting loss of function, predicting an increase in the risk of type 2 diabetes. But when you go to the genetics for PCSK9, you see similar loss of function, similar increase in the risk of type 2 diabetes. So it appears that the increased onset of type 2 diabetes, usually only in people with pre-diabetes, that is more a function of their LDL cholesterol level and not a function of the mechanism of action of the statin group of drugs. We haven't seen it yet with the PCSK9 inhibitors, but Mendelian randomization says that we probably will see it sometime, someplace. So again, a perspective on safety. And I guess I'd like to, we're getting close to the end, I'd like to leave you with the thought of what we might do in future. And I think the next big thing in cardiovascular disease will be the entities of inflammation and a special inflammatory lipoprotein called lipoprotein(a) as novel risk factors for cardiovascular disease. And again, Mendelian randomization has been very informative in this regard. It's probably worthwhile recognizing the role of inflammation in cardiovascular disease. It's long been argued that statins, which are partially CRP lowering, might be having benefit through that mechanism. That mechanism is not seen with the PCSK9 inhibitors. It's not present with ezetimibe alone, but it is present in the ezetimibe used with the statin. And of course, we can develop anti-inflammatory agents targeting components of the inflammatory pathway, which have the anti-inflammatory effects, but not the cholesterol-lowering effects. So if you think of this in terms of CRP levels, CRP as a biomarker appears to be a causal risk factor for cardiovascular disease in adjusted models. But if you take the Mendelian randomization approach, CRP is not a causative risk factor. And so we would be doubtful that this is the mechanism by which statins might be having their benefit, doubtful that it's the right target to select. The Cantos study was a study of cardiovascular disease prevention with that anti-inflammatory approach. It was actually targeting anti-interleukin 1 beta, and that might be a more appropriate target because it did achieve a 15% reduction in cardiovascular disease. There were some interesting side observations. There was a very potent reduction in cancer risk, and that was particularly true, and I think it was a 75% reduction in risk, true for lung cancer. So we'll always be interested in what we can achieve with anti-inflammatory agents, but you're taking a bit of a risk with an anti-inflammatory agent, and here you can see with the Cantos study there was a significant change in, there was a leukopenia, and there was a change in a fatal infection. There were some beneficial anti-inflammatory changes as well, but using the philosophy of Mendelian randomization, we can turn this around and do a thing called a PHEWAS study, which is looking at one genotype, and in this case it would be your, in this case it's the IL-6 receptor genotype, which is thought to be a good target for cardiovascular disease, and you can see what else will show up as additional possible phenotypic outcomes, because here you're listing one genotype against the whole array of phenotypes, and gives you an idea of what the safety profile might look like. As far as lipoprotein(a) is concerned, this is a highly atherogenic molecule, largely under genetic control, and it tends to be retained in the vessel wall. It's transporting nasty oxidized phospholipid, it's stimulating various inflammatory responses, and therefore it's thought to be highly atherogenic. Atherogenic to the point where it even causes aortic stenosis, so it's a risk factor for aortic stenosis as well. And here you see the Mendelian randomization approach. It's a, maybe with a threshold, it's a risk factor for cardiovascular disease with basic adjustment that persists after more substantial adjustment, and genetic polymorphisms also find it to be a risk factor for cardiovascular disease. So the suggestion is that it should be a very appropriate target for cardiovascular disease prevention. The safety aspect, I think you'd make the point that humans and higher apes are the only animals with this entity, and so it doesn't sound as if inhibiting it will be too much of a problem. In terms of the production pathway we talked about, we've recognised as an independent risk factor through Mendelian randomization. The genetic information can be interpreted into an antisense messenger RNA, and we've just started outcomes trials for this agent, but the dosing trials have revealed that a very infrequent subcutaneous injection can get us around about a 90% reduction in levels. So I think these are very exciting times. In fact, there's a lot of hard work to be done, and it's not so much to be done in the lab as in the clinic, because if you think about it, the thing that's missing, we can generate hundreds of thousands, if not millions, of data points from a single sample in terms of genetic information. What we really lack in most instances is the curated clinical data, and that's where the really hard work persists. We still have tricks to learn, I think, as far as genetic interpretation is concerned. At the end of the day, we are talking about huge amounts of data. I meant to pause on one slide to just say, well, these Mendelian randomization studies are usually aggregations of multiple trials and usually have tens, if not hundreds of thousands of individuals, so they are very strongly powered. but we've got to enhance our abilities to handle the data and present the data, and then there'll be all sorts of other ethical problems associated with that, with unknown, unexpected findings and untreatable conditions, etc., etc. We've put our toe in the water as trying to do some of this work locally. So our involvement with the field trial of fenofibrate in diabetes has a GWAS arm to it, and the GWAS is actually looking at diabetic microvascular complications. We will try to generate a polygenic risk score from field, but we'll need to validate it in another population. The UK Biobank is increasingly becoming a resource to which you can refer yourself for acquisition of the information required. And this is the power of biobanks, is that the UK Biobank will sit at the centre of virtually every scientific advance that's made until the bigger and better biobanks come along. There is an Australian connection with all of this. This work was conceptualised by Martin Catan, who first presented the concept at the 1988 Atherosclerosis Society meeting in Melbourne. I visited him just beforehand, and he actually gave a rehearsal talk in Dutch, which sometimes I think I'm still listening to Dutch when I hear some of the statistics involved. But I think he's made a wonderful contribution and developed a very robust approach to things. So Mendelian randomization studies efficiently identify causative risk factors and targets for treatment. The molecular techniques involved can accelerate the development of therapies to address these targets. Australia is really at the starting point for this, and it really requires curated biobanks, genetic analysis, biomarker measurement, etc. And I think New South Wales Health has the capacity to do this. Can we be the UK Biobank or the Broad Institute or Copenhagen, or can we lead the world? I hope so. Thanks, Jerry.
Thank you, David. Thank you. That's a very positive way to end, I think. Thanks very much. It was a great talk. Now we do have some time for questions, so we might, I think we'll just jump out of the slides and see, here we are. Okay, so we've got, I'm just looking at the questions, whether people have added any questions to the chat. I can see Craig Getty, you put a question in, you get cancer because you survive your heart attack. Craig, would you like to talk to that question?
I thought a question might come up about cancer, and I'm trying to think how Mendelian randomization can be used in cancer research. I'm sure it can be for germline sort of situations, and I'll come back to other aspects of that. In cardiovascular disease prevention, I think we're very confident in saying that what's good for your heart is good for the prevention of cancer as well. I think it's also pretty good for the prevention of dementia, which is the other thing that people get very scared about. So I think we've got a consistent message. I think it's much easier than things like sun exposure. You know, what do we do about keeping your vitamin D level up and not getting melanoma? I think there are some areas where our health advice can fall into conflict, but I think cancer and cardiovascular disease are very well aligned. Just trying to think how you do Mendelian randomization and environmental effects on cancer. I think the message would be that if you see a relationship between a biomarker and a cancer, and you don't see a relationship between the genetic determinants of that biomarker and the cancer, it's probably suggesting that it's got an environmental cause. But I haven't, I'd take advice on that. Maybe people would can see a more straightforward way of approaching it.
Does anyone have any other questions? Look, I do have a question just in general about, I suppose, one of the things that we think a lot about in terms of resources such as, genetic resources such as Nomad, about the sort of representation within those cohorts. They tend to be, often Caucasian people, and other, groups tend to be understudied. So I'm just wondering, is that, to what degree do you think are we really harnessing the full power of the population, or are we still overly focused on particular kinds of people in these kinds of studies?
I think the whole idea of the validation is a very important component of that. And I think it's to try and overcome that particular problem. That yes, if we're doing everything in Caucasian populations, we've got to go off and validate it in a non-Caucasian population to look at its generalizability. The other thing is that the other populations will have some different gene pools, which will be better, which will provide a better opportunity to actually discover the things we're really looking for. So just thinking the example of that development pathway is often frustrated because you don't know that you've actually had enough a wide enough capture population to obtain that.
Craig, did you have another question? You've got a question about incidental findings are a beast of uncertainty. How were they managed in this work?
Yeah. So it's a source of never-ending anxiety for this kind of large work. How were they managed in this work? Because it's a really it's still an unknown field for Australian biomedical research.
I completely agree. I think that the main emphasis there is on interpretation back to the individual patient, and most of the work I've been quoting has had a stipulation of de-identified information, and has also often been dealing with consents which allow the use for any purpose. So it's not been so much of a problem at the individual patient level, but I think that it's an important ongoing question for the consenting of future trials. Is that a sufficient guarantee that we won't get into this sort of problem? The other thing is that this work is very much dealing with very small changes. So the Mendelian randomization is your incremental change in something's going to give you an incremental change in a biomarker. It's not so much your genes of large effect model. I think the two are very complementary, but this is dealing with the small change side of things. So I'm sort of wondering, from a cancer point of view, it's almost as if, is there a polymorphism that gives you just a little bit less gene repair, or just a little bit less
maybe in cancer that's not enough. Like if you actually want to cure a cancer, you need to be.
Well, but if that little change is consistent in terms of a lower cancer rate, then it becomes a very appropriate target.
It's telling you something. I guess, I had a question actually about that kind of idea of targets, where you can use these studies to identify new targets, but do you ever get to a point where, from a drug development commercial perspective, the target might look good biologically, but it's not interesting enough in a big enough cohort to pursue? Has those kinds of leads come through Mendelian randomization?
I think that's certainly a possibility. And the other thing I should maybe allude to are some of the practical limitations. You'll see that we were always targeting things which were, the Mendelian randomization studies particularly looked for loss of function variants, because where there's a benefit from a loss of function variant, you can do a silencing messenger RNA.
Absolutely, yeah.
So it's almost as if you've cut out half of the information, because when the loss of function is detrimental, then you're not going to pursue that. The second thing is that current delivery systems are that you're dealing with subcutaneous injection, often with a a ligand which is designed to be taken up by the liver's asyloglycoprotein receptor, and for that reason, it needs to be a target that's largely synthesized in the liver. And as soon as you've got another site of synthesis or you want another site of action, you might be struggling to get the modality to where you want it to. So it's, might have been a slightly gilded view.
Do we have anyone online who has a question for David? You're welcome to jump off mute or add it to the chat.
I've got one more question, I guess, about consent. The relationship to these participants is obviously very strong through the UK Biobank, but it's the consent that allows their samples to be used for future and unspecified work that's the challenge. Is there any experience from the consent process that you can share?
I referred to the field study, and that was very specifically structured as consent for general research use of the samples. And I probably can mainly point to the fact that without that, I think it would be very likely to stop most projects dead in their tracks. Having to go back to re-consent people becomes extremely difficult, and the first part is you've lost all the fatal cases anyway, and so I think it's so strategically important. I could imagine the ethics committees might say, well, you shouldn't even ask for that, but I think I think the consent is often very voluntarily given, and I think that the individuals are protected within that scenario. So I'm hoping that it's the sort of thing that can continue and expand. I might just quickly add, I suppose we really support what I think is the Biobanks approach, which is to say that we're trying to turn every episode of patient care into an episode of biobanking and future research, and that, I suppose, starts to become more difficult because it is going back to all of those issues of the individual, the anticipated finding, etc., etc. But at the end of the day, I think a lot of the public's approach was that, I'm way out of my territory here, but I think sometimes there was created the idea that if your cancer created a cell line and that was commercially useful, that the patient deserved a cut of the benefits. And I think it's becoming better understood now that the sort of separation between the patient's disease and any likely scientific benefit is so great that that they're really unlikely to miss out on any commercial benefit from having given their consent.
I've got sort of, I'm not sure it's necessarily about financial, but there is an increasing anxiety about the use of samples outside of the realm of the project that's already been consented for.
Yeah.
And I wonder if their shared experience of going through this pandemic together will change our culture enough to understand that there are a bunch of things that we can only do with teamwork rather than as rugged individuals.
It might be worth mentioning too that the field study had a great deal of help in its recruitment through Diabetes Australia. So the patient organisations, I guess, tend to attract people who are interested in promoting the study and solution of their problems, and so we were probably getting a select group of patients who are more likely to be enthusiastic about their samples being used for research.
I think it's a good point that we need to be talking about these kinds of benefits and the very real benefits to people's lives that come through these kinds of approaches. it's certainly not to say that there aren't also genuine concerns on the other side, but I think sometimes we have to just make sure that these conversations take place, you know, in an evidence-based context where, you know, if you do this, then we have benefited in this way.
I think it also just points to a better understanding of the areas where the need for effort lie. I mean, as I said, it's already so easy to get the lab information. Just writing down the clinical details is harder. If you then run a scope over that of saying, well, there might be some details we can't record, and there might be, you know, we might need to put extra clauses in ethics approaches, or have some complicated arrangements for different scenarios. The effort needs to go into the human input, not to the machine and the computer input.
Do we have any other questions? We've still got a few minutes.
Yes, I've got a question, or I guess it's sort of a comment on the current status of biobanks. It's Helen Williams from Westmead Hospital. I was curious whether people who've started their biobanks, whether they tend to have their own sort of control group, or whether the biobank as a whole recruits a group of controls, just because I guess I'm curious of whether there's an existing data set for controls in Australia at the moment, or whether that's something people are working to do.
Yes, look, I can.
Yeah, please.
I might answer that. Look, I think not all biobanks assemble groups of controls. You know, some do, some don't. But in terms of a control data set for genetic studies, the Garvan Institute has assembled a control data set of healthy aging controls. I think that's the MRGB data set, and one of my PhD students actually used that to compare rates of particular kinds of variants in cancer predisposition genes. So she looked at her study cohort was children, and she looked at a healthy aging control cohort. So that cohort does exist in New South Wales, and researchers can apply to that, and they can obtain the data and then mine that and do the kinds of studies that we have done. But look, you're right. I think access to control tissue from biobanks can be an issue, and that's often, I think that situation can be facilitated by biobanks having a good relationship with their local pathology departments, because sometimes they can be provided with ethics permission to access controls through pathology. So not everything has to be in the biobank. The biobank can be kind of an extension of a pathology department. Is that an answer, Helen?
Yes, it definitely is. Especially because, so for the FH, for example, they have in Australia the FH registry, and for some people they submit samples for banking or for storage. And so if you were going to do something like this, Mendelian randomization, including FH stations, it would be good if there was also available data for controls.
One thing we're thinking about at the Statewide Biobank is getting having a protocol for, I guess it's called, like a walking biobank or a living biobank, where people give their consent to provide a sample at some point in the future. It's like a permission to contact model. So that can be a good use of resources, in that you're not necessarily, collecting a whole lot of specimens now, but you collect them when you need them.
That's brilliant.
Yeah, look, it's like anything. It's got its pluses and minuses. So that's a project that we're working on.
And it's Craig Getty here. The other possibility is that the Office of Health and Medical Research has done a lot of work on a consent toolkit, which they're very keen to see used as a standard informed consent process for people donating to biobanks in New South Wales, for the very purpose that a sample donated for cancer or heart disease or diabetes or juvenile delinquency or juvenile something could then act as a control for another study. So by having a consent process that's robust and universal, the ambition is that the samples can live and live again and be used again and again, and on as long as the information about those donors is held very carefully, then hopefully that can be something for the future.
Craig, I wonder also, you've raised some very important issues today, and I think there's I think there is a healthy balance that's struck at the moment, and I think it comes partly from the fact that clinicians who know the issues when they're managing individual patients are also overseeing the research initiatives and realise that there is a lot of genetic information that you wouldn't want to know, and therefore I think probably there's a determination to preserve de-identification and make sure that doesn't get broken down. I think if we commit ourselves to lessening a burden of disease, there's a temptation to say, oh yes, and if we find an FH patient in a style, we will get back to them. But I think the difficulties that arise in more delicate areas, Huntington's, ApoE for us, non-paternity, all those sorts of things, I think they're so overwhelming that it's a small price to pay to try to preserve successful de-identification. Do you think we're doing that at the moment? Do you think we're paying sufficient attention to preserving de-identification?
Perhaps when it's my turn to give one of these talks, we can go into that. I see we're over time, and that's an hour. It's an hour's talk in and of itself. But there's so many issues. We're working with partners who care for people from First Nations backgrounds who are happy to donate, but are terrified that the information will then be used by federal or state police as a way of trying to attach individual crimes. So there's all sorts of things, and we're seeing moves by the Financial Securities Council Financial Services Council to try and limit their liability to people who might be unlucky enough to have a significant genotype or phenotype. So there's all sorts of stuff swirling around. So trying to figure out how we protect participants, respect them, look after them, give them the opportunity to learn things without necessarily forcing stuff down their throats. It's a giant minefield.
It is indeed, yes. Possibly the topic of a future talk, Dr. Giddy.
Yeah, you will have a solution in the talk, of course, won't you?
Absolutely, absolutely. Look, I think just in view of the time, we will thank David again for a wonderful talk. I learned a lot, took a lot of notes, and thank you everybody for joining us, and thanks very much to Toby and Renee and also Shane today for their help in terms of taming the beast that is Teams at the beginning of the talk. Thanks everybody. See you soon. Take care.